The committee has selected 6 presentations from the many that were submitted to us because they're very unique things that belong in the community and are very important. So and each, since there are 6 in 1 hour, each is going to be no longer than 8 minutes. And if they're shorter than 8 minutes, people get to ask questions. I think actually, yeah, that's how it would go, 8 minutes for each. So our first speaker is Victoria Lasowski from Beth Israel, who's going to speak on Beacon, which is a digital tool in care for individuals with psychosis.
Hi, my name is Victoria Lasowski. I'm also going to be joined briefly by Dr. Michelle Freeman-Yakubian to talk about our program and its implementation with clinical high-risk populations. Okay. So, as you may or may not know, less than 24% of the psychosis patient population currently receives cognitive behavioral therapy for psychosis, which is the gold standard for therapy. Again, as we've discussed already a little bit today, it seems like access to this care is dwindling. This is compounded by the fact that only 0.57% of mental health clinicians are actually trained to provide cognitive behavioral therapy for psychosis. To combat this, we decided to use our digital clinic model that we've been using for a couple of years successfully for anxiety and depression, now adapted for individuals with psychosis spectrum disorders and symptoms. This clinic model consists of 3 different prongs. So first you have the clinician, which can consist of a clinician of varying expertise, varying levels of training and experience with psychosis, along with the use of the MindLamp app, which is created in-house. This app is used to supplement treatment with different skills and activities that patients can do outside of care, and we'll talk a little bit more about that. We also have a role called the digital navigator, which is usually BA level or college student, oftentimes a volunteer, somebody to help with the app and kind of act as that bridge between the clinician and the app in care. In adapting the digital clinic for psychosis, now I'm going to give it to Michelle to talk a little bit more about that.
Thank you. This is fancy. We're doing 2 speakers in 8 minutes, so yay. I have been really privileged to be part of this clinic as well and kind of helping with the team, kind of adapting for psychosis. One of the things I really love about this intervention is that it can be connect with folks across the spectrum of psychosis, from clinical high risk for psychosis through chronic psychosis. It's meant to be more of a supplement to treatment, not sort of in and of itself, but with the sort of support of the digital clinic team with digital navigators who are usually bachelor's level clinicians. And also it's sort of highly manualized. There's a lot of sort of information available in the app. You can kind of teach this and provide this to trainees that are kind of very new to doing therapy and working with psychosis. And I have a real opportunity sometimes to really help people get a sense of, oh, working with people with psychosis is something I can do and I might really like doing. And that's been a really valuable part of this. So there's the unified protocol, which is a kind of a CBT piece that is manualized, that teaches really just skills for helping people deal with emotional overload. And that is part of psychosis and part of anxiety and part of depression and all of those things. It's meant to be a supplement to treatment. Victoria has done an absolutely beautiful job of manualizing this treatment and writing in a number of pieces into the app to kind of help with specific modules that might make sense for folks who are dealing with certain problems related to psychosis. So here we have an introduction to cognitive biases, which of course underlie in a lot of ways some of the challenges that folks have around delusional beliefs. Here's a look at some of the Beacon Mind Lamp modules, which includes some information related to coping with voices, understanding beliefs, variety of different pieces. And I'm going to turn things back to Victoria to finish this up.
Yeah, so the program in implementation, we wanted to show a little bit more about what this actually looks like because we have an app that does utilize measurement-based care. So patients are often taking surveys, very brief daily surveys, along with some weekly surveys. We like to give this data back to the patient, kind of go through with them, talk with them about their experience, and also talk with the clinician about this. So we have an example of what we give back. It's a data visualization up here. And we also have a patient example with the patient's consent, of course, to kind of delve into a little bit more deeply. So for example, for this patient, in the first 3 weeks of their treatment period, they were struggling with pretty moderate to severe depression symptoms, as well as attenuated psychosis symptoms, as we could see with the graph going into the red. And at this time, this patient was also struggling a lot with their job and added stress that was coming from that. So we're also able to see some of the skills that they were looking at in session and along with the app, again, because the patient was very engaged. They really liked the mindful awareness activities, anchoring the present, values assessment, things like that. And then with this data, we're also able to see the point at which this patient got a new job and things started to switch for them. They experienced a large decrease in their depression symptoms, accompanying with a decrease in attenuated psychosis symptoms, which when we were reviewing with him and looking back, it was just a great way to look at how things have progressed and really push forward what skills were working for him. And finally, across an average of 76 program days so far, we have had clients report around 76% app engagement, meaning that they are using the app every day, or at least 76% of the days of the active program days that they are in the treatment program. And we also are seeing 93% satisfaction with the program due to a questionnaire that is completed at completion. And if anybody would like to learn more, you can scan the QR code or also go to digitalpsych.org/beacon. We have a patient perspective video that's on there. And of course, you can reach out to us with any questions. Thank you.
Because you kept to time, I think we can take one pressing question from someone. Ah, Margaret.
What's the most commonly used part of the app?
Yeah, I would say surprisingly, one of them is the one that we get the earliest, which is self-monitoring. Patients really enjoy being able to look at their day, the thoughts, emotions, and behaviors that accompany just random things, even if that's making a cup of coffee, anywhere from, I was really stressed out at my job and I had this interpersonal conflict this day, and here's what was going on around that. So yeah, I would say that that's the most common.
Yeah, I think this is very important. We're going to see more of this each year. Kesh, did you want to make a comment?
In the world of digital psychiatry, one thing we most often hear is that most of these apps have very low engagement rates. So 76%, very good. What's the secret?
Honestly, I would say the digital navigator, I think having someone there as like a little coach, someone who's not your clinician, who's saying like, hey, you have to do this homework. That's been, I feel like, a really great role to have as like, yeah.
Yeah.
No, I would put out a clinician on this. So folks get to meet with Julia and Billy's around here. Billy loves to say hello to folks as well. And they develop a relationship with that person who does all the troubleshooting and checking in, and that has the clinician. When I sit down with people, I have a record of the whole week in front of me. And so I can go right in and just be like, oh, Wednesday was a tough day. Let's talk about that. What happened Wednesday? And we can kind of use some of the tips and tools that are in the app based on the input that they've had. And that's super fun. So if folks are interested in learning more, please reach out to us. Use that QR code, email me, and we are happy to talk with you.
I think in the right, all these slides will be on the website along with the posters. Okay, our next speaker is Steve Fidel from McLean Hospital, and he's going to talk about well space and peer-led groups. And it's got the sense like that's it.
Wow. That would help. Okay. Yeah, it's a different perspective being here than sitting down. Okay. So I'm here with Lisa Charlin too. She's a peer specialist and colleague in WellSpace. Also a speaker. She does a lot of presentations and speaking in clinical spaces. So yeah, as I catch my breath and let go of my anxiety a little bit, I think the thing I'd like to talk about first, just quickly, is my latest book, Internalization Journaling. This is a process that I developed through necessity and discovery to get myself out of psychosis, to completely get rid of the psychotic thought structures and to figure them out and to deconstruct them and rewrite them. So it's available. It's at all major booksellers. I think at some point it's a major necessity to research it, because for those of you who've known me over the past 8 years, you know how far I've come, and this is the reason, along with a lot of other reasons, people, friends. Yeah, so just want to mention the book quickly. And so Lisa and I are going to talk about WellSpace. Let me see, got this right. Okay. One more. So this is our poster, and we're not going to go by the poster. We have a few different things we'd like to talk about. So I'll turn it over to Lisa for a little bit, and then I have a few things to follow up on. And thanks, everyone. Good to see y'all. Okay.
I love a good podium. I don't always get one. So yeah, in WellSpace, we do about 15 groups a week. They're both in person and online. We've been doing a lot more in-person groups lately due to popular demand. Yeah, we're going to talk about some different elements that we employ in WellSpace. So the first one being the humor element, which I wanted to discuss. So people who are dealing with things like serious mental illness could really benefit from humor or humor therapy, I feel. One thing of note, back when I experienced psychosis about 5 years ago, my husband later noted that, during that time, I was very, very serious. It was a very serious time. And so we definitely incorporate that into our groups so people can have fun, and we feel like that really draws people back to the groups. A lot of times the jokes stem from Steve and I being ancient in comparison to the people that we serve who are 18 to 30. That usually comes up when we play 90s music or make old references. So anyway, so we do that, and we employ it a lot in gaming group. I have a woman who is particularly competitive with me, and we usually are like eye to eye. I'm like, all right, I see you. I know what you're doing. So anyway, so that was one element that we employ, and that kind of has to do with the social element as well. It's not always about therapy and medication. People are dealing with just regular life stuff. We have non-artificial and honest conversations. It's very informal. It's person-first language. We don't use clinical language unless we have a group where we have a therapist co-facilitating. And we don't encourage or discourage friendships, but we find that people are making friends. They're going bowling, they're going to the craft store together, movies, restaurants, etc. We have psychoeducational opportunities. One of our groups is building resilience. So I run that with therapist Allison Nelson Elliott, and we talk about, we have handouts and videos related to different therapies, stigma. We feature TED Talks from people who have lived experience. We have open discussion groups as well, and these are like exploring issues that people are facing, like maybe related to like family, friendships, schoolwork, stigma, dating. So those are the things that often come up, or like just experiencing psychosis and what's that like. And then we have a writing group that's pretty new for us, and this is a great way to like help process experiences. I know that like writing and journaling has been really important to my recovery and obviously to Steve's recovery. Um, and then on the horizon, we have a CBT for psychosis group that's going to alternate with, I'm going to try to read my chicken scratch here, with narrative enhancement for cognitive behavioral therapy, and that's going to be related to self-stigma. And then finally for me, we do individual peer meetings, and these are provided by request or offered to somebody who's having a particularly difficult time. Topics including like learning more about psychosis or dating, job scenarios, family, loneliness, etc. And sometimes people just want to meet with us because they feel lonely and they just want somebody to talk with. So that's it for me, and I'll turn it over to Steve.
Thanks, Lisa. Cool. And I think to mention too, as far as individual meetings, we're in the process of posting a 10-hour-a-week position for a peer specialist to work in WellSpace. The idea would be a few groups and then a lot of individual work. I think the one thing we would like to provide that, just bandwidth-wise, we haven't been able to is the individual peer support and outreach, because not everyone gravitates to groups, which they should, but they don't. So we're providing individual outreach. It's for the On Track Clinic and for WellSpace, which WellSpace is partly the groups program for On Track and the vocational and individual peer support, but 80% of our clientele are outside referrals. So thank you all for those referrals. I think, to cover a few things, the pathos of WellSpace, we believe in a lot of positive psychology, a lot of happiness. We ask people what's good, what's happening. I think Martin Seligman's book Flourish is all about positive psychology. We think a lot about what's going to make someone happy today, what's going to make them laugh. In our discussions and crafting our groups and our support, a few years back, about 7 or 8 years ago, we had 2 residents who came up with the gaming group, and we're like, this is our most popular group. So what are we missing? We got to do more of this. And then we figured out over time that so much of therapy and so much of life with psychosis, in my own experience too, or there's so much negativity and loneliness. You come out of therapy talking about all your toughest traumas and life experiences, and then you go into a space at home where it could also be a negative environment or just difficult, or you're lonely. So after thinking about it more, it's yes, we need to foster the skills to be positive, to be happy. And that's a big part of WellSpace, and why WellSpace works so well is we're focusing on the happiness. We're focusing on how to foster authentic social connections, which therapeutic dynamics are more authentic, and that's artificial, and that's more expected. But as peers, we can be more authentic and honest. There's a saying in the peer literature that you try to offer what you're good at or what you can provide as a peer. So as peers, I feel like our peers, we're very socially oriented, and that's what we try to provide. It's if someone can hear how a conversation is supposed to go, what to say, what not to say, how to turn, what to do, body language, and they learn that authentically through honesty, it leads to other things like getting back to work, getting back to school, making friends, being able to just go to the store and pick up a prescription if you're struggling. So there's that element. I think in addition, this past year, we've been more holistically oriented. We had a holistic wellness group for 6 years, and then it kind of petered out. As you know, some WellSpace groups peter out, and then we offer new ones, and then we alternate. And but with so you all might know Marnie Chanoff. She's our holistic wellness consultant, and her and I meet every so often, and we come up with different ideas for the program. I think in particular, we're implementing a lot of exercise. We have gym access, which is games and the basketball court. And then we also have fitness center access, which is the weights and the machines and all that stuff. So we have that. We're implementing a lot of walks. We have trails, and we do a lot of campus walks. And I think during all this too, there's something that happens called informal recovery, or that's what I call it, where like we have a lot of informal conversations. It's not like focused or structured, but people just want to talk. And if you're going through psychosis, like that's the thing on your mind, like it's just there and it's present. So like through all these physical exercise activities, there we go. You know, people just want to talk about what's going on in their lives, and we just talk honestly and like informally. So there's a lot of informal recovery. In particular, we have tea that we leave out. We have a little tea kettle with tea. We have snacks, like health-oriented snacks. The well-spaced room, if anyone's ever seen it, we try to make it as naturalistic as possible. We have a lot of natural colors like greens and browns and blues. And then we have a picture of the ocean, which is really amazing. We had a client who's a photographer, so we worked with him and bought some photography from him. He's outside of our program, but just like someone we knew, and that was great. So yeah, I think overall our orientation is towards positive psychology and towards holistic wellness. And we're working on a lot of the things that we know therapeutic services can't directly address. So that's one of the successes for WellSpace. That's the secret. Time is up. Thank you.
That was great. I just want to thank all the peer specialists that are here. It's such an important profession that we have, and these are such important members of our coordinated specialty care teams. They keep our patients engaged, and without them, I don't think we'd be able to do our work. So thank you all. Okay. Our next speaker is Cardine Joseph from Boston Medical Center, assessing the current state of a reverse integration primary care clinic for patients with severe mental illness.
Hi. Good afternoon, everyone and friends online. My name is Cardim. I'm one of the PGY3 residents at Boston Medical Center in the Family Medicine Psych Residency Combined Program. And I want to talk to you about our Prime Clinic. So just for background, I think as many of us may know that patients with severe mental illnesses have a lower life expectancy. And a lot of that, there's different factors for that. One of the ones that we are addressing is delays in receiving care, whether it's medical care or mental health care. There are different barriers that contribute to why patients may not engage in care. We heard a great talk earlier about integrative behavioral health in the PEDS clinic. This is kind of the exact opposite, where we're embedding a primary care clinic into the psychiatry clinic. And there hasn't been many data about how to build that type of setting up. But at BMC, we have the Prime Clinic. And for background, it was started by one of our prior residents, Dr. Rohit Abraham. For the sake of time, we're going to skip a lot of it. But for how things are done right now, the clinic is not funded. It is staffed by the PGY5 FM Psych residents who staffs with a FM attending later on, and they kind of coordinate all of the care as far as referrals, as far as follow-ups, and going from there. And of course, a lot of shareholders involved with the administrative teams, nursing directors, front desk staff, et cetera. So Prime Psychiatric Reverse Integration for Medical Expertise is just a room, exam table, blood pressure cuffs, thermometers, everything that you would see in a primary care clinic. We have a room of that in the psychiatry clinic right now. So what is it currently standing at? So we have about 66 patients in Prime right now as of last month, 2 months ago. About 80% of those patients have a severe mental illness diagnosis. Half of those patients are within the WRAP program, which is our Wellness and Recovery After Psychosis program. And half of those patients are in the first episode Psychosis clinic as well. One of the biggest outcomes that we are prioritizing is engaging in primary care. And so what we found, about 1/5 of Prime patients have since been connected to primary care somewhere, whether it's in family medicine clinic, internal medicine clinic or at a community health center, which is huge because if one of the big barriers is getting them connected to care or engaging in care, a good portion of them have followed up with providers outside of Prime. So there's just allowing greater access and getting connected into care better. And a couple of different things that were treated. Specifically for our first episode psychosis patients, there are a bunch of different diagnoses that were addressed. We have where there's hyperlipidemia, psoriasis, alcohol-induced gastritis, gender-affirming care, iron deficiency anemia, metabolic associated liver disease. I didn't include that in the slides, but those were some of the things and diagnoses and chief complaints of patients that we've treated in Prime Clinic. And a bunch of different referrals and medications prescribed, specifically some of the mortality benefits, treating vaccines with Tdap or pneumonia vaccines, hepatitis vaccines, or treating with GLP-1s for weight management. As we know, that's a big side effect that a lot of our patients have to deal with. And a bunch of different referrals that have been placed between ophthalmology, physical therapy, GI, urology, a bunch of referrals that have been placed and that patients have followed up with, which is likely care that they may not have received had they not been a part of the Prime Clinic in the first place. So what's next for us? I'm kind of flying through, but one of the biggest things for us to do is increase our psychiatric providers' awareness of Prime as a resource. We talk about it all the time, and then every once in a while you hear, oh, I never know this was a resource. And that's something that we can improve our availability and how much providers are aware of us as a resource in our clinic, and also standardizing the referral process. Right now, the process is if providers know, they send a message to the resident who is in Prime right now, and they set up all of the follow-ups and setting up the appointments and going from there. If we can have a more formalized process and improving how people engage and making it easier easier to place that referral, that could be a big step for us going forward as well. And also collecting more data. Love to make data-driven decisions. And so one of the things that we want to look at is how are we improving medical outcomes, whether it's decreasing the total ED visits or the total overall healthcare costs and the primary care show rates. And then, like we talked about, improving outreach, scheduling, and developing a warm handoff that can potentially improve how often patients actually show up to the appointments and going from there. So Prime works. It's improving access to care. It shows a lot of promise in decreasing those barriers, and we'll just continue to expand and meet that growing demand and go from there. Any questions? Yeah. So the question was, how often are we using GLP-1s in clinic? And that is one, there's at least one, I know for a fact, at least one who has been prescribed a GLP-1 for weight management. There are a couple that have gotten nutrition referrals and other things like that, but that is definitely a big part of it as well. As long as they meet the criteria, of course, we definitely have a couple of patients that are prescribed GLP-1s.
Any other questions?
Thank you.
Yeah. Just to respond to your question, also, we have a lot of patients at Cambridge Health Alliance in our RISE clinic that are going to their PCP and getting them for weight control, and it's been very successful, actually. Okay, so our next speaker is Gil Grunfeld, who is a PhD student at BU and also doing her thesis in the RISE clinic at CHA. Gil.
Hi, everyone. My name is Gail Grunfeld. As Lynn mentioned, I'm a PhD student in clinical psychology. I'm also very grateful to be a clinical trainee and a researcher with the RISE Clinic. I'm going to be speaking with you today, briefly, I have my timer up here, about an NIMH-funded project that I'm running with our program about the experience of loneliness in early psychosis. So loneliness is defined broadly as a perceived lack of social connection, and this can be for a number of reasons, including a reduced number of social interactions, as well as difficulties or challenges within the quality of social relationships. And I hope also by the end of this very short presentation that I convince you that it's also probably for many other reasons. As some of you may have heard, the US Surgeon General declared that there was a loneliness epidemic in our general population. And since that declaration, there's been a great number of studies examining the uniquely greater prevalence and also detriments of loneliness in a psychosis spectrum population. These are just some of the recent studies that have come out. So we know that something might be interacting here differently with our people. And despite this research, little is known about many of the facets that might contribute to and exacerbate loneliness, specifically in an early psychosis population. So, for example, we know that loneliness is fluctuating, it's dynamic, and at times it can also be momentary as well as trait-like. Loneliness is contextual and environmental, so different positions that you're in, both kind of on a societal level, but also the actual lived environment you're in can contribute to loneliness. Loneliness is an interpersonal process that can bring up many interpersonal experiences, not included but not limited to feelings of shame, stigma, etc. And then, of course, loneliness may interact uniquely with the symptom dimensions of psychosis and this unique phenomenology of early psychosis, including developmental factors considering the age range and the lifespan period that early onset psychosis covers. So the study I'm conducting at CHA is in 3 waves to try and better capture these different domains that might be impacting loneliness in a first episode population. So in the first wave, participants arrive to the setting and complete battery of assessments to better understand kind of their baseline clinical dimensions, but also their social life, their trait loneliness, and their experience of stigma, as well as other kind of social behaviors like cannabis use. And I hope many of you got to see JD Beck's wonderful poster using some of the qualitative data on cannabis use and loneliness earlier today. The second wave is a 2-week ecological momentary assessment period where participants download an app on their phone and in day-to-day life respond to survey questions around their social context, how they're doing in that moment, as well as experiences of stigma and shame and loneliness. And then this bottom piece here too, momentary qualitative data, which I'll share with you in just a moment. And then finally, a subset of patients will have completed qualitative interviews to better kind of understand their lived experience, both around what it's like to be them in day-to-day life, but especially what loneliness means to them. Loneliness is very multidimensional and can also be very personal. And so these qualitative interviews can really kind of help us better understand what we're talking about. So our current sample, these are preliminary results I'll be showing you today. The study's currently underway. We have 17 participants and 18th is filling out surveys right now. And I just want to draw your attention to the state loneliness scale of our kind of population. So we use the UCLA loneliness scale, which allows us to kind of assess people's trait loneliness. So to orient you to this graph, the score ranges in possible amounts from 20 to 80 as a range, with 40 and above being what's considered moderate to severe loneliness. So our sample here kind of is parallel with some of these wider epidemiological studies on loneliness and psychosis. So a pretty lonely group. There's quite a bit of data that's being collected across these different waves. So to better kind of elucidate some of the potential mechanisms that I'm interested in, I want to share with you a case study of one of our participants from this fall. So this is B. She's a 21-year-old young woman who's a member of our program and who's participated in the study. So you'll see here, this is B's EMA data. The question she's self-reporting in this moment, I feel lonely, with 1 being not at all and 7 being extremely. So this is over 14 days. You can see again, loneliness is incredibly dynamic and fluctuating. I want to draw your attention specifically to these 3 peaks of loneliness, not only because empirically there's potential predictive analyses that we can't yet do, but that I hope to do, but because I have qualitative momentary data that Bea shared. A text box pops up when she responded, and she was able to share her responses to why she felt lonely in this moment. You see that the first peak over on the left, Bea reflected on some of these more contextual environmental factors that may have contributed to her loneliness. The middle peak here, Bea reflected on an interpersonal challenge she was experiencing, potential symptoms exacerbated by that challenge. And then this last peak on the right, we see something that several of our speakers have discussed today: potential experiences of internalized stigma and shame, as well as maybe responses to externalized stigma in the past that really might be giving way to a higher degree of loneliness in that moment. And when Bea returned for her qualitative interview at the end of the 2-week period, she reflected on what loneliness meant to her. And Bea also reflected on, the difference between feeling lonely and being alone, but maybe not feeling so lonely at all. So there's several clinical implications to this work that I want to close out my presentation discussing. The first is the importance of daily level insights, which we saw in our first talk today. From a more intervention standpoint, thinking about detection and intervention on an individual level, both for the patient themselves to get a better understanding of their own patterns, but as well, thinking on a wider level in terms of the clinic as a whole. When are people starting to feel lonely and why? There are developmental considerations that I was not able to speak as much about today, but our program encompasses both, adolescents and teens, as well as emerging adults. And especially, I hope the qualitative interviews can maybe highlight how the experience of loneliness and the social needs for individuals might differ across different points of the lifespan, and that is something that we should consider. And then lastly, the insights from our participants, and all of whom are patients also in our clinic, can help us better understand the unique challenges that they're facing, specifically around loneliness. And as researchers and individuals who are hoping to implement more tailored care, understanding what we're talking about when we're talking about loneliness, having hypotheses that are generated from the ground up and from the individuals we seek to serve, is really a major ethos of this research as well. And I believe I have a little bit of time for questions, so thank you so much.
I'll just make one comment that I think before I met Gil, I had no idea that loneliness was so important in patients with psychosis. I've been doing SCID interviews for years and years, and the BPRS rating scale, and none of that deals with loneliness. It's just amazing. She really opened my eyes to how important this is. So, questions? Drew.
Thank you. This is a great talk. Since you do have a little bit of time, could you speak to some of those developmental considerations about positive experiences of this?
Yeah, absolutely. Thank you so much for asking, Drew. So just to summarize the question, Drew mentioned if I could speak a little bit about the developmental considerations that have come up in our qualitative interviews. The impact of social dynamics looks a little bit different in our younger, I guess, I want to say 14 to maybe 18-year-old, more high school aged population than maybe some of our emerging adults. Some of what I have noticed actually is participants' reflection on, quote, how much they need other people and what that means looks a little bit different. So especially some of the teenagers reflect on very rapid changes in their social groups, and that their loneliness comes from trying to figure out maybe where they fit in. And that's where I hear people say, like, well, I don't need so-and-so anymore. I have this new friend. And what does that mean? And especially in trying to understand your social identity and kind of what group you belong to. And some of our older participants, I can think of one or two, who actually spoke about loneliness as actually stemming from a lack of connection to their self. So feeling maybe more dependent on other people and less autonomous in their day-to-day life, actually might contribute to greater loneliness. So again, that paradox, that might seem like a paradox at first, but loneliness is just as much about interpersonal challenges as it is self-related challenges. And that's something that I believe could be developmentally specific. I hope that answers your question. Yeah, thanks.
Thanks, Gil. I think this is a very important topic, and we'll certainly continue it next year and keep at it. So next speaker, and Andrew Hyatt and Jamie Back from Cambridge Health Alliance, and they are talking about unmet needs, assessing the effects of substance use and discharge practices on CSC service users. Andy?
Thank you, Lynn. We'll aim for 7 minutes. I'm Andy Hyatt. I'm a psychiatrist and health services researcher at CHA.
I'm Jamie Beck, and I'm a PGY2 at Cambridge Health Alliance. We both talk really fast, so
Really
we
fast.
apologize for that.
I don't apologize. We're great. We're here to present some qualitative data on unmet needs, assessing the effect of substance use on service users during and after CSC. For some quick background, we all think coordinated specialty care is wonderful. It works while people are in it. There's very mixed literature on whether the gains last over time, particularly for people from disadvantaged backgrounds, particularly for people who use substances. Prior research from myself and our group identified some risk factors for relapse after coordinated specialty care. Chief among them were ongoing cannabis use at discharge, as well as hospitalizations while people were in RISE or CSC. There's unfortunately little data that CSC improves substance use outcomes. The big analysis from RAISE didn't suggest that it improved outcomes at all. There's been some qualitative work on SUD trajectories in CSC, kind of hinting at some of the things that we'll talk about today. And so we really wanted to understand how substance use during and after transition out of CSC affects people's trajectories.
So the approach that we took is a mixed method study of CSC transitions, and we're focusing specifically on the qualitative portion. We interviewed 17 participants who graduated from RISE at least 1 year ago. Most of them graduated around 2016 to 2019. There were also some participants who graduated during the pandemic as well. So the interview guide focused on the experience of treatment in RISE, as well as substance use before and after RISE, as well as the transition out of the CSC. So we focused specifically more on the questions on substance use, as this was a lot of preliminary analysis. And so data analysis is very ongoing. It's very preliminary, and we'll share some of the themes that we've uncovered so far.
So the first theme that came through pretty loud and clear was that participants remember little substance use treatment or education. The parentheses here should be aside from being told that drugs are bad. So everyone could be like, okay, yeah, my psychiatrist told me that I shouldn't drink anymore. I shouldn't use cannabis. Or I heard this in group that cannabis is bad for people with a history of psychosis, but people remember very little beyond that. I think this quote here on the right side here, I'd like, quote, I don't think they focused much on my addiction, and I think that's something we could actually improve. So I was still using and going to therapy, but I didn't have medication that could help me. This participant says something interesting later on we'll get back to as well. And here on the left, you see, they didn't talk about it much except tell me that psychosis was caused by cannabis, then using cannabis could make it worse. Of course, this is all several years ago, but it's this is what stuck, right? Which is very little aside from the basic message.
And another thing that we found was that changes in substance use were common, but seemed to stem organically from the recovery process rather than substance use treatment itself, as well as just life events. Things like the birth of a child, or moving to a different location, or starting a new relationship, starting school. These were the events that really mattered when it came to changes in substance use. And then the quote on the right was also interesting because it's from a participant who found a friend in the substance use treatment group. And it was that relationship with a friend and the accountability that they had to stay sober with each other that he cites as really important to changing his substance use.
So this person wasn't lonely anymore, so they didn't use cannabis. The last thing that really came out to us was that the co-use of cannabis with tobacco, alcohol, and other substances was often underappreciated and underaddressed. Kind of like we mentioned before, most people reported the message that they shouldn't use cannabis. Whether or not they made a change in that is a different question, but most people report getting that information. But we had a lot of people who talked about that, either cannabis was not the only problem they had, or maybe even in their minds was not actually the most important problem that they had, but they didn't get a lot of intervention or treatment for this other thing. So the participant on the right talked extensively about how problematic alcohol was for them and how challenging this was for both their mental health and substance use recovery, and that they really didn't recover or start to recover until well after they left the CSC and had a really kind of bad experience. I said, quote, "I think drugs probably maybe a little more contributed to the psychosis, but alcohol is really the only one that I had a problem with. So while maybe the cannabis made the psychosis worse, he really identified alcohol as a more problematic one." And then we have another participant here on the left who talked about co-using marijuana and tobacco, talked about smoking spliffs, so kind of having cannabis in a tobacco leaf. Talked about how the use of those two things together made it really hard to quit both. And then I don't remember if there's this or the other participant talked about how no one had actually offered her nicotine patches until well after she had left CSC, right? So kind of a pretty basic, like easy intervention that maybe could have helped both with her physical health and mental health was not addressed, or at least again, she did not remember it being addressed at that time.
So we have some early takeaways. So again, participants seem to remember little formal substance use education or treatment. There could be lots of reasons for this. They are recalling their experiences years later, but also maybe something about the education did not stick with them and wasn't tailored to them. I have a little poster on the motivations for cannabis use, which you can check out later too. But the most common things that they remembered were counseling on meds and substances and substance-induced psychosis. But a lot of it didn't quite stick for them. And then many participants also made changes in their substance use that were pretty tangentially related to CSC treatment. And this happened both during and after RISE. And part of this could be the CSC, but also all these life events that we discussed earlier.
Couple kind of future directions or hopes. The first one that came immediately to my mind was the ability to integrate more harm reduction into psychoeducation. I mean, there are certainly some people, I don't want to speak too disparagingly about telling people to stop using, because for some people that did it. Some people are like, yeah, my doctor told me to stop using cannabis, so I stopped. Or they told me I couldn't drink on my meds, and so I didn't. So that kind of first step really does hit some people. But then there's a group of people who it doesn't work for, who it seemed like, at least in this sample, people kind of didn't know what to do then. The participants didn't know what to do. The clinicians didn't know what to do. And so how do we work with people who are not ready for abstinence or who are kind of struggling to kind of get to that point? And thinking about applying things like the lower risk cannabis use guidelines to our patients, talking about lower potency use, substituting CBD for THC whenever they can, using less frequently, things like that. Secondly, it seems like a really obvious place to be able to integrate peers, employment education specialists, family intervention specialists, given how prominent these other factors were in people's recovery journeys, people making kind of changes to their substance use because of social relationships, because of jobs, moves, things like that. And then finally, more integrated treatment of polysubstance use and co-occurring substance use versus focusing only on cannabis. I'm saying this to myself. I'm a cannabis policy researcher. I think about this all the time, but it's important to remember that this is not the only thing that's going on in our people's lives, and how we can help people with cannabis use, but also the other things that are really common. Tobacco and alcohol, of course, are going to be the most common, and other things there as well. Thank you so much.
Thank you. I wonder if we could get Andy and Jamie to help us write a part of the Navigate model, the manual that will cover treatment of substance abuse in these patients, because it's a very overlooked thing. And I can also say, Andy, that even though your patients were from even pre-pandemic days, I'm afraid to say this, but we're still saying the same things to the patients and not really helping them this far. So, okay. Yeah, go ahead.
Very generally all around. We see a focus on absolute focus methodology being overall less efficacious than harm reduction methodologies. And due to the pressures of our industry, these psychosis research is primarily focused on using harm reduction as a vehicle to get to abstinence. you think this orientation is affecting people's care and the amount of resources that we're actually able to give them benefit?
I think that's a great question. I'm someone who's I'm sorry, restate the question. So it was about harm reduction in orientation towards abstinence versus orientation towards actual harm reduction, and sometimes using harm reduction as a Trojan horse for abstinence, if I can kind of paraphrase you right. And I think that's a great point, because I think often we kind of tell people we want them kind of to cut down or use less riskily while secretly hoping that they'll stop. And I certainly do that all the time. And I think the way to think about it too is that harm reduction can be both things, right? So I think it's not that harm reduction is never a vehicle towards cessation, because that is often the best thing for somebody, but that you can't only want that to be the outcome, right? That you have to on its own be happy with progress somebody made. So for instance, I had a patient just the other week who had been using cannabis waxes, which are really, really concentrated, like 95% THC. And she made a change, and she's now using cannabis flower and using a little bit less frequently. And that's a win. And I kind of celebrated that with her. And we kind of talked about would making more changes result in further improvement? Would you do that? So the point is really well taken. I think it does. There are limitations to that. And I think we have to be able to hold some dialectical thinking. I think can kind of be both be true at the same time. That it might be better for many people to stop using entirely, but also that there are victories, and we shouldn't have that be the enemy of the good.
I would also add that from a child and adolescent perspective, even just delaying 1 or 2 years for cannabis use makes a big difference on outcomes. I just think the horse is out of the barn. We're at the commercialization stage of cannabis in Massachusetts. It's not going away, and we need to learn to work with it.
Yeah. But with that, Andy, I wonder if you could just say one sentence about your paper that was just published about legalization of marijuana.
Sure. So much of my work right now is looking at cannabis legalization and outcomes in people with a history of psychosis. We just had a paper come out a couple weeks ago in JAMA Psychiatry showing a really big jump in cannabis use among people with psychosis after legalization, about 3 times the size of that in the general population. So this is kind of hitting our patients and hitting them actually potentially even more hard than the general population. So more good news to come soon.
Okay, thank you. All right, so our last speaker is Rashni Mukherjee from Boston Children's, Psychosis Literacy and Caregivers of Youth with Early Psychosis.
Thank you. Hi, everyone. Good afternoon. I'm just gonna try and figure out this first. Yes, okay. Yes, good afternoon. My name is Rashni Mukherjee, and I'm a graduate student of mental health counseling at UMass Boston. I'll be presenting here today on behalf of the Developmental Neuropsychiatry and Psychosis Clinic for Dr. Ruizu. Shout out to Dr. Ruizu right here. Where I have been collaborating in her research exploring early onset schizophrenia spectrum disorders in youth. So, oh, yes, absolutely. I could not, yeah, sorry about that.
You can keep talking, I'll do the text.
All right, yes, so we are focusing on EOSSD, right, which is, so schizophrenia spectrum disorder, it's the primary symptom of that is psychosis. And it typically presents in the late teens to early 30s. So yeah, why does this matter, right? So early onset is when symptoms present before the age of 18. For youth with EOSSD, caregivers and families play an important role because psychosis literacy, which is how early caregivers can recognize symptoms in their children, how they govern access to timely care, right? So caregivers and families, a psychoeducation, a collaborative approach has been shown to reduce mortality rates by 90%. So that demonstrates the critical need for family involvement. early interventions have been shown in evidence-based research to improve treatment outcomes and even during the delivery of care, right? It is important for providers to collaborate with families and caregivers by involving them as more active participants in the process, providing psychoeducation and community support resources. So, given the kind of lack of treatment available for youth with early onset schizophrenia spectrum disorders and the notable importance of including families and caregivers in treatment, our research group is kind of focusing on working towards adapting existing measures, such as your McFarland's multifamily groups, and making these modalities like more inclusive, more adapted to diverse populations. So current challenges that we have, I think one of the biggest ones is like the delay in recognizing early symptoms or misattributing it to adolescence or stress can lead to delayed referral, which can ultimately delay, general literacy outcomes as well as worsen outcomes. So we have like studies have shown that psychosis education can elevate caregivers' burden by 56%. It can increase efficacy of the intervention by 35%. Like I mentioned before, there is a reduction of around 90% of mortality rate, which is like really high. And there's also a 32% less likelihood of relapse. So this situates our research in a very critical place. So the methods we use to develop our psychosis literacy measure for caregivers, it kind of like we started early this year by consolidating our research focus, by sifting through literature reviews, existing literature where we identify the gaps and pull relevant measures for our study. After that, based on our literature review, we followed the define, operationalize, and confirm process. So that was defining it. After that, we have generated the items. These were like items we pulled from different measures. We identified thematic domains. So health literacy, efficacy beliefs, attribution of illness. These were kind of representing the overarching, most common overarching themes that are influenced by or themselves influence psychosis literacy. These items were parsed by a panel of experts, including psychiatrists and psychologists at BCH. So currently we are in the confirm phase of it, where we are kind of going through a cognitive interviewing process along with administrating the measure. And this allows us to kind of enhance the validity and reliability of the measure by getting participant feedback and insights from the cognitive interviewing process. So I'll be talking more about that. We named the measure CarePsy, which is Caregiver Awareness and Recognition of Early Psychosis, quite a mouthful. So that's CarePsy. The measure itself is it's currently 19 items. We did add upon it a bit. The format is multiple choice, Likert scale, and it also has a few open-ended questions. Inclusion criteria for this is you have to be a caregiver to a youth below 18 who meets criteria for EUSSD. You have to be fluent in English and provide consent to participate. The measure is kind of like we use that parallelly with cognitive interviewing, which itself is a qualitative, semi-structured interview. When we administer the measure, we are also doing the cognitive interview parallelly with it, which kind of gives us insight into the kind of cognitive faculties that participants are using to come up with the measure, with the answers during the measure, right? So their comprehension, their retrieval, judgment, responses, kind of what their thinking is when they are answering the questions. So we also have a detailed guide for the interviewers, and they are kind of prepared to kind of preserve the standardization across all the participants. So here are some sample items from the measure. So version 1, I mean, how confident are you that professional help would help your child's symptoms, right? So not at all, very confident, slightly confident. It's your standard Likert scale. The probes that we have, can you rephrase this in your own words? Did you think of a particular time, right? So these are kind of, we don't always ask all of them. These are kind of to guide the interviewer and select like one of them based on how they think the participant is interacting. So these questions would kind of help understand why the participant chose like maybe slightly confident over moderately confident, right? So this is another sample we have. it's more of a multiple choice question here. Select the symptoms of psychosis that might apply. So the probe here, probable probe here would be, what does psychosis mean to you in this question? Can you recall, how did you recall that answer, right? So these would kind of help us understand better how participants are responding to the measure, and that would kind of inform further iterations. So currently, these are the next steps that we are looking at. We are already wrapped up with data collection and cognitive interviewing. So caregivers of the EOSSD youth enrolled at the DNP clinic at BCH, that was where we got our data from. Phase 2 is the data analysis, which is where we are incorporating our findings from the cognitive interviewing, from the expert panels that we have, and kind of specifying each code gets like specified into decision thresholds. So you have retention, deletion, and revision. The next process would be a review of the content and construct validity, right? Where we are using iterator agreements to address any kind of redundancy that you might have, any kind of ambiguity that you might have in the questions, so that each iteration is more improved, more enhanced for cultural responsiveness as well. Future adaptations that we are looking forward to is generalizing it across diverse racial, ethnic, socioeconomic, and educational backgrounds, adapting it to other childhood onset SSDs and other SMIs as well. Implications, how this can help, right? So we do hope that the insights that we get from the participants, right, and our research can facilitate more culturally responsive psychoeducation. This in turn can promote better symptom recognition, better confidence, and health-seeking efficacy in caregivers, right? Which ultimately it would influence timely referrals and how that can reduce the duration of unfettered prognosis, which in turn overall better outcomes. And just greater awareness would lead to greater clinical engagement, and that's what we as providers are trying to bridge the gap between caregivers and providers and how they access services. So in conclusion, we are the last phase that we have, phase 4, kind of loops back into phase 1, where we keep revisiting and refining our work and care side, the measure, to influence further adaptations, how especially for diverse populations, for caregivers whose needs are unique according to their children and other individuals with SMIs as well. Long term, we hope to see this kind of increase more awareness, give traction to policies that can support collaborative partnership between caregivers and families, psychoeducation, capacity building, overall reducing caregivers' needs, burdens, and meeting them where they're at with their unmet needs. So that brings me to the end of my presentation. It was a pleasure presenting to you all today. Thank you. And if you have any questions, feel free to share.
Thank you. Educating caregivers is extremely important. It helps keep patients engaged in our treatment for a few years. So thank you for this work. Any questions before you leave? Anyone?
I have a question.
Yes.
Can you say more about the cognitive interview? The cognitive interview and what that was about?
Absolutely. That's a great question. Thank you for asking. So we are going to be expanding more on the cognitive interview. What we do is we have the measure, and parallelly we run the cognitive interviewing process. So if they're answering the measure and they have a particular answer that they select, we kind of probe into what prompted them to think that way. We kind of get an understanding into the kind of cognitive faculties. So selection, retrieval, recall, how they're using that to come up with the answer. So that kind of helps us decide how relevant the item is to understanding how they perceive psychosis.
So are you assessing the cognition of those caregivers?
Yes. Not to, so Dr. Brunellen, yes.
Oh, I think the term can be confusing, but we're not assessing cognitive functioning, it's not a cognition like assessment, but it's like the process of gathering like their process through which they answer the question. So it's like cognition is a thinking process, not so much like a cognitive assessment, but just yeah, in that way.
Thank you.
Yes. Thank you.
Thanks, so much. Thank you. Okay, so community spotlight. I'm now turning this over to Dr. Keshavan, and this, I believe, is an award session, right? Yeah. So no one leave because you might be getting an award. No?
Thank you, Kelsey. So this brings us to the most enjoyable part of the day, which is to give out awards for the best posters. And we have two of those. The first one is Francisca D. Marneff for her poster on relationships between employment and loneliness in psychosis. Francisca?
Oh, sorry.
Congratulations. The second award is for Tisha Chatterjee for her poster Faces, Virtual Spaces, and Social Functioning, Early Markers of Impairment in Psychosis Risk Syndrome. Tisha? Is there anyone from her group that could receive it on her behalf? Oh, great, you get two awards. Second.
Oh God. Okay.
Oh, yeah. That brings me to the last part of this meeting, which is really my pleasure to give a brief summary for those of you who may have missed parts of this, or those who may have been online and may not have gotten everything. So what I will try to do in the next 5 to 10 minutes is to give an overview of what all we learned, so that we kind of keep those take-home learnings and come back with more ideas that are stimulating in a year or so, and apply these lessons that we learn in our practice. So, it's always a pleasure for me, I can speak for myself, to come to these meetings. This is the one meeting as Margaret was saying, I most look forward to every year. It's like a beautiful coming together of a community and learn as we go along. And, we talk about two kinds of research: those research initiatives that are grown in a ivory tower lab or a university. And then we apply that to the community. And then there are those that come from the community and give ideas for the researchers in the university settings. And so it becomes a beautiful blending together of those. And that's exactly what we are here. And, in fact, the title of this conference is very aptly termed From Research to Practice. And I would call it Research to Practice and Back to Research, and vice versa. It's kind of a bidirectional thing. We started this morning with a keynote presentation by our own Emily Klein. She's still here. Yeah, there you are. For Emily, it's a homecoming. She grew up with us. And, she was the first project director with MapNet. She set up a lot of things, which is now flourishing, as you see. And she, like she always has done, she's a non-conformist pioneer. So she learned early intervention and all about psychosis that she could learn, and then went into the real world, into primary care, pediatrics. And comes back to us with her insights, which I'll just briefly summarize. We all live in this world of early course psychosis, but that's probably to be thought of as only the tip of an iceberg. The large part of the iceberg is a broad range of psychiatric illnesses that exist underneath. And out of the 255 cases that she has seen, only 6 had psychosis, right? But there were all the other 249 who had other kinds of problems. So one needs to keep in mind that psychosis is a tip, but there is a lot underneath, and we need to be aware of that. And even when it comes to psychosis, Emily pointed out to us that it may be uncommon in primary care practices, but it may be partly uncommon because not everybody seeks help. Number two, it's also possible that our screening instruments may be too blunt and we may not be picking it up. And number three, many people who have these early illnesses resist treatment. They're afraid of psychiatry. From what you brought up, it's important to keep that in mind. And we need to make mental health services much more palatable and accessible to address this. Emily also pointed out that psychosis, when it presents to us in primary care settings, can be quite variable in its manifestations, and also can be quite variable in its outcomes. Some of them just go away and get better, and some of them get worse. And what an important insight that she taught us is that in many cases, all you need is just reassure them. Take good care, reassure them, and be available. So that's Emily. And then we went on to a very, very insightful poster session. Now, I won't be able to, review all of the posters to you, but I, learned a number of things myself. And I'm sure you would have learned a number of things that surprised you. So I'm going to ask you all some questions, and what do you think? And if you have seen the poster, you would know the answer right away. But if you didn't, then I'll tell you. So, first question. Where is that? Yeah. Which symptoms, if improved with treatment, would best predict improvement in quality of life? Anyone? Trick question. None of them do. Symptom improvements do not improve quality of life. What does improve quality of life, as Megan Good showed, is improvement in your functioning, work-related function. If there is a purpose to get up in the morning and go somewhere to work, that itself improves quality, not whether you hear voices or not, which is important too, but that may not be the sole determinant. That's just one example. Now we have with clozapine the ability to do a finger prick instead of this blood test every week. So which kind of blood test do patients most prefer? Do they prefer a finger prick, or do they prefer being poked into the vein? The phlebotomist. That's I was surprised by that. The people actually prefer the big vein being pricked and not the finger being pricked. So these are things that we learn from practice. It's important to know. Third thing, I'll give you 4 choices. Which medicine might be most commonly associated with a higher use of GLP-1? Risperidone, olanzapine, aripiprazole, clozapine. You would say clozapine, right? Clozapine was the least likely to be used with GLP-1. So this was one of the posters that I showed. I'm not remembering all the names of the people, but these were all wonderful. All posters today were great, but I'm just picking some examples of some surprises. The answer is clozapine is the least likely. I think it was risperidone and olanzapine were at the higher end. Now, food insecurity, how common is it? Is it common among people with serious mental illnesses like psychosis? The answer is no. When it was looked at, the proportion of people with a diagnosed psychosis illness who also had food insecurity was less than expected. And the number of psychiatric diagnoses among those who were receiving services for food insecurity was also pretty low. So maybe, something is not connecting there in terms of the services there or their perceived need. So let me see. There will maybe okay. So if you compare two interventions in psychosis, social skills training and cognitive enhancement, which of these two treatments is more likely to improve cognition? Any answers? Russell Schutt has shown the surprising finding that social skills training also improves cognition just as much as cognitive enhancement does. Even though, interestingly, cognitive enhancement improved social outcomes even better and community functioning. That was a surprise. Last one, insight. Does it improve during the course of psychosis or does it get worse during the course of psychosis? In chronic patients, is insight worse or better? Any answers? It's worse? No, the answer was no. The insight is at its worst early in the illness. And then it gets better for some reason. So the important lesson from that, this is what Pega Saif showed in a poster, that psychoeducation is most important in the first few months or years of the illness. That is when the insight is at its worst. So after the poster sessions, we went on to what we call community spotlight. And, we renamed that section as emerging initiatives. So I made some notes and, I won't go into a lot of those details, but just to quickly summarize, Victoria Lesowski and Michelle Friedman-Yakubian, they described a really innovative approach to digital clinic using a platform called Beacon, which really surprised me as to how high the engagement was, 76%. On average, engagement and attrition rates with smartphone apps in digital psychiatry is less than 10%. But to get it to 76% is real good news. Steve Fidel and Lisa Charland presented about their really exciting work with WellSpace, with peer-led groups. Really they pointed to the importance of using positive psychology in these kinds of consumer-led groups. Humor is an important skill and person-first approach. Congratulations to them. Karim Joseph, he described their Prime Clinic, which is a innovative clinic for enhancing the interface between primary care and psychosis treatment. And, it's kind of an integration of medical care and psychiatric care with a warm handoff and enhancing access to care. Gil Grunfeld pointed out the importance of understanding loneliness in first episode psychosis patients. Loneliness is quite common, more common than we would have thought in patients in the early course of psychosis. And investigating and understanding loneliness on a moment-by-moment basis or day-to-day basis can really help us understand our patients much better and also help us intervene early and improve quality of life. Andrew Hyatt and Jamie Bike, they described their experience with treatment of substance abuse in first episode psychosis And the one thing I learned, which clinically is very intuitive that I had known as well, is that comorbid use of nicotine and cannabis is worse than either of them alone. They might have some kind of synergizing with each other, and so treating one of them could treat both. So that's the important part that they pointed out, and also the other approaches of harm reduction, and keeping in mind the importance of integrating treatment of psychosis with treatment of substance abuse. And am I missing any of these? Roshni Mukherjee, presented along with her mentor Bernalyn Ruiz, the innovative literacy tool, psychosis literacy tool, which could be so valuable in enhancing our efforts at psychoeducation, early detection, really something that needs to be developed and widely used. So that's the summary for today. We still have an exciting day tomorrow, and it's called Bridges to the Future. And the whole exercise today and tomorrow is all building bridges with the community, and building bridges across our understanding in the different phases of the illness, and between basic science and clinical work, and between early illness and long-term perspectives, and so on. So this is what we are going to hear. I want to end with thanking all of you for participation, and also thank really two unsung heroes here from the get-go who have been part of this, which is Margaret Gaia and Kelsey Johnson, without whom this coming together of this wonderful family of early psychosis caregivers and the other stakeholder community would not be possible. Thank you.
Thank you, everyone. So I think that's it for today. It was wonderful having you all here, and I hope you'll join us tomorrow online.